Welcome to the first part of our discussion of the heart, which is chapter 18 in our Human Anatomy and Physiology text. I have a hard time saying that, Human Anatomy and Physiology. Okay, now that we know something about the blood, which is the medium that carries nutrients and oxygen and CO2 and so forth and waste around the body, we're going to have to propel that stuff, and that's what this chapter is all about. Here's a diagram of the circulation, which is kind of helpful to start right out with. The heart is actually two separate pumps that are unconnected within the organ of the heart. The left side of the heart, the left ventricle, is a big, meaty, muscular chamber which can squeeze down and eliminate blood, force blood out into this large blood vessel here we see, which pumps blood out to all of the cells of your entire body. This little web network represents capillary beds in every organ and tissue in your body. And then once that blood passes through all those capillary webs or beds, it joins into veins and comes back to the right side of the heart, the right atrium here, down into the right ventricle, a smaller but muscular chamber that can squeeze down and force out the blood into the pulmonary artery. So the pulmonary circuit, pulmonary means having to do with the lungs. So the blood's going to the lungs to get oxygenated, comes back to the heart through the pulmonary veins to the left side, to the left atrium, and I'm going to do it all over again. So those are two pumps and two circuits, systemic circuit to all of your body, head to toe, and then pulmonary circuit to your lungs. This is just a slide to kind of show the position of the heart in your body, to clarify that. You kind of already know roughly where it is, but that gives a little more detailed perspective. It's right up against your sternum and right behind your ribs there, a little bit offset to the left. Here we're looking at a transverse section, and we can see the heart nestled in among the lungs. The heart takes up some space and everything's packed right in there. It kind of notches out some space which you might otherwise think would be occupied by the lungs. And here we can see the heart from another point of view. We can see in its cavity, body cavity, surrounded by its enclosure. There's a fibrous connective tissue jacket around the heart, which we see here, all attached to the diaphragm, to all the great vessels of the heart and so forth. So the heart is in like a leather satchel, a non-elastic bag in which it operates. I guess we can mention that since we've already studied all the tissues. You know that the serous membranes that surround the lungs are called the pleural membranes. The parietal pleura on the pleural cavities, the visceral pleura, the second layer of that two-layer membrane on the lungs. Here we have the pericardium around the heart in the pericardial cavity. And again, there's a serous membrane pair. There's a parietal pericardium and then a visceral pericardium on the heart, and the two membranes are lubricated and the heart can glide and writhe in that space without any friction to speak of. The pointy part of the heart that's sitting right against your chest wall and against your diaphragm is called the apex. And I'll point that out a couple more times as we go. I stuck this picture from Gray's Anatomy in here just to show you a posterior view so you can kind of get a feeling for where things are. There's not much anatomical detail in this picture other than to emphasize the heart and the great vessels and the pericardium. Here we can see the trachea and the primary bronchi, the heart sort of sitting anterior to those structures, and then the aorta, the huge artery that pumps blood out to the systemic circulation right here, comes up from the heart, forms the aortic arch, and then will come down posterior to the pulmonary arteries and pulmonary veins and the bronchus there, the primary bronchus, on down through your diaphragm into your abdominal cavity. To give it a little more detailed look at the surrounding, the sac, the coverings of the heart, we see that the outermost part is called the fibrous pericardium. It's again like a leather satchel around the heart that's woven onto all the great vessels of the heart and completely surrounds it. Attached to that is the parietal serous pericardium. And that's that lubricated epithelial sort of membrane that's lining this body cavity enclosure. And then we have a visceral layer of serous membrane, the visceral pericardium, that can then, again, glide against that parietal pericardium. When it comes to the heart, the visceral layer is called the epicardium. So the fibrous pericardium and the epicardium. Then we come to the myocardium. And you may remember from chapter 9, myo means of muscle. So that's the muscular part of the heart. It's a I don't think I like this drawing. It makes it look like a slab of steak. I'm not sure that's the actual way that the fibers would look in there, but anyway. The endocardium is the lining of the heart. There's a layer of epithelial cells lining the heart called the endocardium. And they're actually essentially the same as endothelial cells. They're continuous with the cells that line all of the blood vessels, the veins and arteries. So that's the heart wall in a nutshell. What if it becomes inflamed? Inflammation of the linings of the heart is called, the outer linings is called pericarditis, the pericardium. A low level of inflammation may cause dryness in the serous membranes and scuffing, painful scuffing and rubbing of those layers. You can actually hear it in the stethoscope if someone has pericarditis. As the disease advances or inflammation advances, you could actually have fusion attaching between the layers, which will really impede the movement of the heart, sort of putting it in a straitjacket. And the most serious type of pericarditis or degree of pericarditis, there's fluid that's going to start to accumulate in between these layers. And since the fibrous pericardium cannot expand, it's not elastic, that fluid in there pushes the heart walls inward, and the heart can't fill with blood in order to pump out blood to the rest of the body. So that's a very, very dire situation indeed, called cardiac tamponade. Tamponade means there's some fluid in there in the pericardial space there. It shouldn't be there, and it's impeding the ability of the heart to fill with blood and then pump it out. Could be blood in some instances, but that's just a general term. Endocarditis, if there's an inflammation of the inner lining of the heart, if bacteria get into the blood from, say, a surgical dental procedure, they sometimes will take up residence, attach themselves to the endocardium or to the heart valves, and begin to colonize that area and cause inflammation. Also, some viruses will colonize the endocardium and sometimes even the myocardium and cause inflammation. That's called endocarditis, a very serious condition indeed also. The muscle fibers of the heart, obviously not all are shown here, but just to give you a feeling, they're built up on a collagen skeleton of the heart. And the fibers are arranged in sort of a wrapping, circular wrapping arrangement, so that when the muscle cells contract, they wring the blood out, up and out of the ventricles. First down, wring out the atria, down, pushing blood down into the ventricles, and the ventricles then push the blood up and out into the great arteries. There's just a dissected heart. You can see some features of the heart, which we'll be looking at in a second. One thing I call your attention to is the auricles of the atria. Here's the left atrium and the right atrium here. And the atria have these little wing-like regions. If you opened up the atria, you'd see there's a dome-shaped sort of chamber here that can fill with blood, but then there's like around the rim is like a narrowing and a wing-like region. And this is exactly where blood will clot if you have atrial fibrillation. If the blood is coming through great veins through the atrium down into the ventricle, but the atria are not contracting, some blood's going to hang out in these auricles and start to clot because of stasis. And then maybe chunks of fibrin will start tearing off and getting into the lungs or into the brain. All right, let's look at some anatomy here in this much more sort of clear vision of what's happening here, idealized cartoon. Here we see the great vessels of the heart, the aorta and the aortic arch. We see the great arteries that branch from the aorta. Those are important ones. We'll learn in lab the names of all these branches and so forth that lead to the arms and the neck and head. You can see the pulmonary trunk, another great artery, the other great artery of the heart, and the pulmonary veins that, pulmonary arteries that carry blood to the lungs. I should review a very important definition in just a second. Here we see the superior vena cava and inferior vena cava that are the return pipes in the systemic circulation that return blood to the right side of the heart. We see the pulmonary veins that return blood from the lungs, right? The pulmonary arteries send blood out to the lungs, and then it returns to the left side of the heart in the pulmonary veins. We'll take a look in a little bit about at the coronary arteries. You hear a lot about coronary arteries, right? They get clogged And we have heart attacks because of insufficient flow in these coronary arteries here and here. So we'll take another look at those in just a bit. But a quick definition, arteries are vessels that carry blood away from the heart towards capillary beds. Veins represent any vessels that carry blood back towards the heart. It's not about oxygenation, because here we can see the pulmonary arteries are oxygen poor, but they're arteries because they're carrying blood away to the lungs, and the pulmonary veins carry rich oxygenated blood back to the heart to be pumped out to the systemic circulation. I will mention also there's like a little scar here between the pulmonary trunk here and the aorta. It's called the ligamentum arteriosum. You can see the word ligament right in there, some connective tissue. In the fetal circulation, there used to be a trap door here, so the blood from the pulmonary trunk could sneak right over into the aorta and enter the systemic circulation. And that opening, that little doorway, it was called the ductus arteriosus, and I do want you to know that because it's too fascinating not to know. The ductus arteriosus allows blood to cross over from the right side to the left side through these great arteries in the fetal circulation. At childbirth, that duct closes and it begins to heal over and forms the ligamentum arteriosum. Sorry for covering up all the words there. There's a posterior view of the heart. You can see that the pulmonary veins carry the blood, all four of them from the two lungs, carry the blood back to the left atrium of the heart. And here you can see the inferior and superior vena cava bringing blood back to the right atrium of the heart. Left atrium over here and right atrium. All right, let's look inside. Now we can see, looking once again from an anterior perspective, so the left heart is over here and the right heart over here. We've cut it open, and one thing I'll mention is look at the thick, meaty wall of the left ventricle. The left ventricle has to pump blood under high pressure through the entire systemic circulation, all the capillary beds nearly of your entire body. That's a lot of work it has to do, so to raise the pressure very high to be able to do that. And hence you need a big, strong muscle. The right ventricle pumps only to one organ, and it's a very elastic organ. And the vessels in the lungs are very stretchy and elastic, so it's a low-pressure circuit, the pulmonary circuit. But the right heart has to pump the blood through the pulmonary trunk and pulmonary arteries and through lung capillaries. Let's take a look at the valves. There's 4 valves that we can see here. When the blood enters the left atrium, it immediately starts to flow down into the left ventricle through the mitral valve. You should definitely know that term, very important. Mitral valve, and bicuspid it's also called because it has 2 sort of flaps that can close together and then open. So then blood passes through that valve down into the ventricle. When the ventricle contracts, blood goes out through this little valve. It looks like a little baby's butt there. Blood will push its way through that valve into the aorta. Blood can flow that way, but blood cannot go back from the aorta back into the ventricle, just like blood cannot flow back through the mitral valve into the atrium. Then when blood comes back from the systemic circulation to the right side of the heart, it passes from the right atrium down into the right ventricle through the tricuspid valve. There are just 3 kind of leaflets, they say, that slap together to close off this valve during contraction of the heart, of the ventricle. So blood cannot flow back up into the atrium. It's forced to go out into the pulmonary trunk through this little valve. So the 2 valves in the arteries are named for their arteries. This is the pulmonary valve, or pulmonary semilunar valve. This is a semilunar valve. See how it looks like a little crescent? Looks like a little crescent moon. Here is the aortic valve, or aortic semilunar valve, and blood goes from the left ventricle out into the aorta through that valve, but can't come back. Here they show those 2 valves closed, but when blood is pushing up against these rounded surfaces, the leaflets can lie flat against the arteries and blood can go right out. But when blood tries to go back down, when the heart takes a rest, can't. So we'll see more about the valves in just a bit, and I'll mention it again. So let's see what else we can find. The valves have to close during the violent contraction of the ventricles. They're made of collagen fibers, and the fibers form like ropes or ligaments that attach to finger-like projections of the myocardium muscles, called papillary muscles, that contract and pull down on those chorda tendineae, they're called, that hold on to the valves and keep them from flipping inside out when the ventricle contracts. So when the ventricle contracts, these leaflets, as they're called, of collagen can slap together, and they can't turn inside out because of this. The chorda tendinea are attached to the papillary muscles, and which are attached to the ventricle wall on each side. That's pretty cool. There's also a lot of like strange irregularities in the wall of the ventricle. Now those are called trabecular carnia. Just a feature of the ventricles. You don't see that in the atria. That sort of rough-looking, weird structures on the walls of the ventricles. All right. One last thing we should mention. In the fetal circulation, blood can sneak from the right atrium right through a trapdoor over into the left atrium to go to the systemic circulation. That opening was called the foramen ovale, the oval foramen, to let blood across from the right side to the left side. So we've got two features of the fetal circulation that let blood go from the right side to the left side, and that's because in the fetal circulation, instead of oxygen-poor blood coming back from the systemic circulation through the vena cava, the inferior vena cava, that's where the rich oxygenated blood is coming from the placenta. So we have the rich blood coming to the right side of the heart, and we need to get that blood right out to the little body that needs that oxygen, so we're going to let some of that blood come down into the ventricle, go into the pulmonary trunk, and then cross right over into the aorta to go out to the tissues. We're also going to let some of that blood from the placenta go into the right atrium, cross right over into the left atrium, down into the ventricle, and then out to the systemic circulation. It's because now, once the baby is born, then all the oxygen's coming in from the lungs, and we can close off those passageways and run things the way we will for the rest of your life, with just the right and left side being separate. Again, as I said, here's the two pumps and the two circuits right here. That's how it is once the baby's born. This is the way the circulation, the pathways of the circulation. This is just a fun diagram to show you a cool concept. That is, that the collagen skeleton of the heart is especially thick around the heart valves. All the heart valves, surprisingly, perhaps, lie in one plane. And so what we've done here is made a cut through, in this cartoon drawing of the heart, an imaginary cut through the heart, and remove the base of the heart, remove the atria. We see that all four of the valves lie in one plane, and they're all surrounded by a tough collagenous skeleton that holds them so they can't deform and be pulled open at the wrong times. They're very, very tough surrounding of the valves. Another thing we can note about this is the leaflets. Here's the mitral valve, and we know this because it has only two leaflets. It's the bicuspid valve. This is the valve between the atrium and the ventricle on the left side. Here's the tricuspid valve because it has three leaflets that, shown here closed, they've slapped together during contraction of the ventricle. Now we see the semilunar valves here. One thing I should have probably mentioned, the artery valves here are called semilunar valves. These two big ones are called AV valves, atrioventricular valves, atrioventricular. So the left AV valve is called the mitral valve, the right AV valve is called the tricuspid valve. All right, here's just a dissection showing the same thing in an actual heart from a cadaver. And here's just a fun picture showing an illuminated interior of the heart. And we can see a papillary muscle, the chorda tendinea, and a little bit of the valve tissue up here. It's kind of like parachute fabric, very tough but very flexible. You can see the illumination of this chamber of the heart. This dissection just shows very vividly. Look at the thickness of the muscle of the left ventricle wall. It has to pump blood under such high pressure to send out to the systemic circulation. Here we see the right ventricular wall is much more lightweight, so it doesn't need to pump blood with such high pressure through so much resistance. Okay, so the heart has no idea where it's pumping blood. It just contracts and reduces the volume in the chambers, and the blood is forced to go somewhere. Where does it go? It goes in one direction only, because each one of these valves we've been talking about are one-way valves. The heart just contracts, and the blood moves in the direction it moves because of the orientation of these valves. When the ventricle contracts, the blood can't go up into the atrium, because here's what happens. Here's an AV valve, open, blood going down from the from the left atrium into the left ventricle, and then when the ventricle contracts, blood tries to go right back up into the atrium, but it can't. It gets up under those leaflets and they slap shut, making a violent sound, which is what we hear in the stethoscope. When you listen to the heart sounds, you hear the closing of the valves. By the way, when you listen to sounds in the body, that is called auscultation. It's a strange word. Put the stethoscope anywhere in the body to listen for sounds, whether in the heart, the lungs, the GI tract. That's called auscultation. So when we auscultate heart sounds, we're hearing the valves slapping shut during the contraction of the ventricles, and then slapping shut during the relaxation of the ventricles when blood tries to go right back. We'll see in a second. Okay, so the AV valve closes. And then where does the blood have to go when the ventricle contracts violently? It goes right out through the semilunar valves, in this case out into the aorta presumably. Oh, maybe if the angle is right, this is probably the pulmonary trunk. So the pulmonary semilunar valve. And blood gets ejected from the heart, we say. But then when the ventricles contract and they rest. They contract and they rest. When the ventricles take a rest, blood tries to go right back down from these stretched out elastic walls of these big arteries. It tries to go right back down in the ventricle, but it can't because the semilunar valve slaps shut and makes the second sound of the heart cycle. The lumped-up sound is produced by AV valves, semilunar valves. AV valves closing, semilunar valves closing. Okay. So here comes some blood from the systemic circulation through the vena cava into the right atrium, goes down into the right ventricle, right, filling up the right atrium, goes down into the right ventricle, and then when the ventricle contracts, the AV valve is going to close, and blood's going to go out into the pulmonary trunk. That's by the virtue of the valve action and the contraction of the heart. On the other side, when blood comes back to the heart from the lungs, then we just sent it up to the lungs, now it's coming back to the left atrium. It's going to flow into there and then down into the left ventricle. This is not like a stopping point. We just drew that to make it clear what's going on. The blood, as soon as the heart relaxes, blood starts to go right back down into the ventricle and right through the AV valve. It doesn't like stay here for a second and then wait. It goes right down in and then it fills up the ventricle. When the ventricle contracts, the AV valve closes and the blood is forced out into the aorta. This is all very artificial because there's never the ventricle always has blood remaining in it after a beat. So I'm not sure I love these drawings, but whatever. They're just trying to show you what the valves are doing, I guess. Let's take a look at the coronary arteries. Very important because of their importance in cardiovascular disease. Coronary artery disease is a major problem in middle-aged people, especially men in our society. So right after the aorta emerges from the left ventricle of the heart, immediately two arteries branch off from the aorta, the left coronary artery and the right coronary artery. Then the left coronary artery branches, forming the circumflex artery, which passes posterior to the heart, and the left anterior interventricular artery. Interventricular, so over here's the right ventricle, over here's the left ventricle, and this kind of runs right along the wall. It's also called the left anterior descending artery, LAD. It's probably a more common name used in cardiology for the pathologies that take place. Left anterior descending artery. So you should know those names. Over here, the right coronary artery forms the right marginal artery, which travels right around the posterior of the heart. Or here's the right marginal artery. The right coronary artery passes right around the posterior of the heart. And look what happens. It meets the circumflex artery in a little web of artery vessels, and the LAD connects onto a branch from the right coronary artery in the posterior of the heart in this little web of arteries. Those are called anastomoses. We'll see, I'll have it written down for you in just a second, another slide. Anastomoses. So let's say if we pinched off part of this left coronary artery, the LAD, theoretically blood can go through the right coronary artery, down this way, going backwards through this anastomosis, back up through here into all these branches, sending blood to all parts of the heart. So the heart has this sort of collateral circulation away to get blood to all parts of the heart in the event of an emergency. However, we can get the vessels can become so diseased that there's still going to be some emergencies in which there isn't enough blood flow to the heart and part of the heart tissue will die. So those anastomoses allow us to have collateral circulation, alternative routes to get blood to the heart. The disease we're talking about is atherosclerosis. Plaques, abnormal tissues, and fatty material build up in the wall of the vessels, closing them off progressively. That's called occlusion. Occlusion means closing off of the opening, narrowing the opening, so it's harder for blood to get through there. We can't get enough blood to the heart, and when that happens, there's pain. When the myocardium becomes hypoxic, the term we use is ischemic. I-S-C-H-E-M-I-C, ischemic. We have pain, and that's called angina or angina pectoris. Very classic thing that I'm sure you've heard about. It's during injury to some of the tissue of the heart because of ischemia, because of some narrowing of coronary arteries. Well, if one of those arteries has a really narrow spot, and we suddenly start the heart pumping real vigorously because either we get upset about something, some emotional event, or we start to do some extra exercise we don't normally do, like going outside and really shoveling the driveway for the first time in who knows how many years, then one of those plaques may rupture and just burst from the wall and really start closing off the opening of the vessel, and at that time a blood clot will form because of the violence of the turbulent flow of blood in that little narrow opening. And then once the blood clot forms, we have a myocardial infarction on the way. Infarction means death of tissues due to insufficient blood flow. So we start out with pain because of ischemia. Now we have, frankly, no blood flow to some part of the heart, and the tissue is going to die. That's what a heart attack is, a myocardial infarction. So dead tissue is ultimately going to be replaced with scar tissue. And that's good. We at least don't have the heart burst open and all the blood rush out and form cardiac tamponade. But once you form some scar tissue from where dead heart cells were, it's no longer going to contribute to the contraction of the heart. And the more you put these collagen patches on your heart, from heart attack after heart attack, the heart gets weaker and weaker. This is very bad stuff happening here, obviously. The cardiomyocytes have to do aerobic respiration at all times. If they get into a situation where they don't have enough oxygen to provide all of their ATP for contraction by aerobic respiration using mitochondria, or if the mitochondria become damaged, then there's going to be anaerobic respiration. No can do. Lactic acid is going to come on the scene. It's going to cause changes in the heart muscle cells, fatigue, right? You can't just have your heart fatiguing. This area where the fatigue is happening, eventually the cells are going to die and be replaced by scar tissue. So all that blood in the coronary arteries will pass through all the capillaries around all these cardiac muscle cells in the wall of the heart, myocardium, and then coalesce into veins, which are also located on the surface of the heart. And all these veins will carry blood back to the heart through this great vein in the posterior of the heart. It's called the coronary sinus. If you look back to the cartoon we had earlier of the posterior of the heart, you can really see this big bulging vein back there called the coronary sinus. And it carries all that used blood from the heart right back to the right atrium. That's what that little circle is where it's grafted onto the right atrium. We don't need to know the names of the veins. Don't worry about that. So that brings us to the end of part 1 of our discussion of the heart of chapter 18. So join me next time as we get more into how we regulate the heart cycle. What's going on there?